Now we will discuss iron deficiency anemia in special patient groups. Iron deficiency anemia in children and adolescents. Rapid period of growth increases the body demand for iron, putting children and infants at risk of anemia. Children who develop anemia have a high risk of developmental delay and infection. Risk factors are prematurity, small for gestational age like low birth weight, poor dietary intake of iron fortified or iron rich food. Example, exclusively breastfeed infant greater than 4 months of age not receiving iron prophylaxis. Early and excessive intake of non-fortified cow's milk and restrictive diets like malnutrition mainly in resource limited countries, eating disorder including pica and picky eating. Pica is the craving for the eyes and dirt. GI bleeding like Meckel diverticulum, heavy menstrual bleeding, intellectual disability, low socioeconomic status including living in an area with a high prevalence of IDA. IDA is a risk factor for peat-led toxicity. Cow milk is a very low concentration of iron and also disrupt iron absorption. Clinical features are similar to those in adults. Commonly asymptomatic, young children can present with irritability or pica, and children with anemia have increased risk of infection and developmental delay. Screening, so screen children with risk factor for pediatric IDA at set intervals. Consider screening all infants at 12 months will child visit. Diagnostic CBC to confirm anemia. WHO definition of anemia less than 6 months so varies depending on the age. If the child is 6 to 59 months, so less than 11. 5 to 11 year less than 11.5 and 12 to 14 year less than 12 when considered as anemic. Iron studies to confirm a diagnosis of IDA recommended for most patients. Management severe anemia, so we give pure RBC transfusion and admit the patient. All other give IV iron or oral elemental iron. Mild or moderate, so oral elemental iron is given. Prevention of IDA in all children. Encourage the recommended daily dietary intake of iron. Ensure formula or breast milk until 12 months of age, and at around 4 to 6 months of age introduce age appropriate iron rich food. Example, iron fortified cereal and pureed meats, which is the processed meat. At greater than 12 months of age, limit low iron milk like cow milk. In children with risk factor for PID, start iron supplementation. Example, in term breastfeed infant greater than 4 months of age, elemental iron until there is adequate intake of iron-rich food, for example, iron-fortified cereal. Premature breastfeed infants, elemental iron is given until 12 months of age. Do not introduce low iron milk, for example, cow milk, before 12 months of age, and do not routinely start iron prophylaxis in children who receive frequent blood transfusion because of the risk of iron overload. Now idea in pregnancy epidemiology, so 30 to 50% of pregnant individuals worldwide develop iron deficiency anemia during pregnancy. IDA is the most common type of anemia during pregnancy. Causes, so there is increased fetal iron requirement for RBC production and fetoplacental growth and increased RBC mass. Clinical features do not significantly differ in pregnant individuals, and screening, so recommended screening times. Females are screened for the IDA in the first prenatal visit and again at 24 to 28 week of gestation. Consider screening once during each trimester. Diagnostics, so routine CBC with smear to confirm anemia if not already obtained during screening. Iron studies to confirm the diagnosis. For example, ferritin level less than 30. Diagnostic HB level, first trimester less than 11, second trimester less than 10.5, and third trimester less than 11 gram. In pregnant individual with non-severe microcytic or normocytic and nothing to suggest an alternative cause, IDA can be presumed and empirically treated. The diagnosis is confirmed with appropriate increase in HB concentration within 2 to 4 weeks of initiating iron therapy or with confirmatory testing for IDA. Management, severe anemia HB less than 7, significant symptom, example, hemodynamic compromise or HB less than 6, so pure RBC transfusion and admission. While in asymptomatic patient, parenteral iron therapy avoid in the first trimester or oral iron therapy. So in significant symptom, we give pure RBC transfusion and admit the patient, while in asymptomatic patient, parenteral therapy or oral therapy is given. but avoid parental therapy in the first trimester. For asymptomatic, mild or moderate anemia is greater than 7 oral elemental iron. Complications, so there will be increased risk of adverse maternal and fetal outcome like low birth weight, neonatal anemia, and premature labor. Impaired fetal neurodevelopment. Prevention, encourage patient to consume recommended daily dietary intake of iron. So it's all about anemia in children and adolescents and anemia in pregnancy.